Welcome to Seating Technology, an Analytical Approach, presented by Faith Brown. This clinical education webinar was originally delivered as part of a live global series created and presented by a team of clinicians from all over the world. In fact, this webinar is coming at you from the United Kingdom. My name is Angie Kiger, and I'm currently the Clinical Strategy and Education Manager at Sunrise Medical US. Throughout this webinar, you will be hearing my voice, as I served as the moderator for this series. We appreciate you choosing to watch this recorded on-demand version of the webinar. I believe you will find the information presented by Faith very helpful. With all of that said, on behalf of Sunrise Medical's Education in Motion team, here's Faith.
Hello, welcome to everybody. Really happy to have you here. Just briefly, I'll say one or two things about myself. Thanks for the introduction, Angie. I am, of course, Faith Brown, and I'm the clinical specialist for Sunrise Medical UK and Ireland. So I look after the education program here. And one thing I've discovered, I'm an occupational therapist by training, and whilst the university education was absolutely critical in what we do, probably over the years, about 70% of what I've learned has been clinical experience on the job or through little workshops or things like that. So I'm really happy to be able to support my colleagues in this way with continuing education. I've had experience here in the UK, also in North America, long history with the NHS, also private practice and some independent work, charity sector. And one thing I've discovered that I also noticed Amy said is that you'll find the fundamentals of good practice aren't that different no matter the setting. So today is going to be all about fundamentals. I'm going to turn my camera on now so you can see me, which is kind of nice. Hello, everybody. You'll find that you can change the size of me. And in fact, I'm going to change the size of myself by dragging. There's a little bar there if you want to have more of the presentation or more of me. That's something you can customize on your own screen. And we're having a little bit of a delay. That's going to happen sometimes with the slides. There might be a little bit of a lag. But the next thing we're going to get into are really the objectives for the day. And what today about is, of course, an analytical approach to seating. And what that means is when you go into the clinic, you want to have the highlights that you do every single time so that you have a good outcome for you and for the client. The equipment works in the way you want, and what you get is the right sort of thing. We're still just waiting. There's a little bit of a technical lag here. I know we had some of this in practice, but I think while we're waiting, the next thing I wanted to say is just thank you to all of you. I know that all of you are busy, you've got a lot of responsibilities, and particularly because this is the time of COVID-19, a lot of people are working at home and dealing with a lot of responsibilities at once, so I really appreciate your time. I'm not sure, Angie, if you're able to bring up the poll because there's a bit of a lag.
I was about to ask you. Happy to do the polls right now.
Yeah, see if we can do that. Just wanted to find out where people are from. We've got now 902 have signed on, so I'd be interested to hear where everybody is coming from today.
All right, so Faith has a little question here for you guys. We want you to chime in. She can't see the answers, I can, so we're going to give you guys about 30 seconds or so. It's multiple choice, so you'll be able to actually jump in and answer some questions. It only allows us to have 5. I did have somebody ask me, well, how come every country can't be represented? We're only allowed 5 slots on this quick little poll here, so bear with us. Ooh, Europe is going up, Faith. We got 2% from Asia or Australia.
Oh, well done.
I know,
staying up 2 o'clock in the morning.
10% from Europe calling in. Some of your folks over there. 86% of us are from North America. Now, remember that includes all of North America, so it's not just the US. We've got a lot of Canadians calling in too. And we've got 1% from South Africa and 1 from other. Once again, we respect you, even though you're listed as other. Let's see here. How about we do the next poll also, Faith?
Yeah, I think that'd be good. So the next thing I'd like to know is really what would you like to get out of today? And again, I apologize, I can't just ask it as an open question because we have such a volume of people here. But if you could just write in and let me know what you would like to get out of today on the poll, that would be really brilliant.
Yes, we are the educators that you guys are having the opportunity to listen to. We're all used to being face to face with you guys, so it's interesting. It's fun for me. I didn't tell you guys where I'm from. I'm actually right outside of Washington, D.C., our nation's capital here in the U.S. So it's a sunny but cold day here. Um, Once again, Faith is calling in from the UK office. We are practicing social distancing within Sunrise, so only a couple of people are there with her today. Don't worry, we are definitely honoring that that social distancing. All right, Faith, let's see. 41% would like a better understanding of matching technology to your clients.
Okay, great.
24% are looking for more familiarity with postural issues and wheelchairs. 12% looking for information specifically related to seating assessment. And 24%, they're open to everything. They're new to seating and wheeled mobility. They just can't wait to learn. So, all right, last disclaimer I'm going to give before I shut up for a little bit is that bear with us, as Faith did mention, she was having a little bit of technical difficulties. I don't know if you guys are aware or have seen it in your practices across the world, but we are definitely dealing with a we'll say a global delay in internet across the world. We're noticing it as we have our phone calls within the organization too. So, all right, Faith, I'm quiet. It's you.
Thanks so much, Angie. Just one last bit of housekeeping. I have a content disclosure. Just wanted to say I am, of course, an employee of Sunrise Medical, but this training is all about clinical things. It's not to endorse any particular product or manufacturer or anything like that. It's all the fundamentals. And that's worked out well that 25% of you are open to anything. And I think no matter which one of those questions you answered yes to, they are all going to be in this training. The one thing that won't be in here because of the disclosure is I'm not going to talk about Sunrise Medical products specifically, but if you want to get that kind of training, you can contact your local Sunrise, and that's something that could be looked into. Right, so let's talk about goals. And I want to put this right at the top because no matter what else you do in your assessment, goals are absolutely critical. There's a lot of different ways you can think about your clients' goals and how you can work as a team to come up with those goals. But a helpful way to organize those is to look at 4 different areas. They basically break down into physiological goals, mental goals, skin protection, and function. And I like to talk about what does that mean in everyday English. Basically, physiological is anything to do with how the body works. And sometimes I think actually as clinicians, we feel very comfortable there. It's the measuring we do, putting people on the plinth. Some of it's a bit more subjective, things like pain, tone, posture, absolutely critical, but it is only 25%. The next bit I want to talk about is mental. And the reason I bring that up, it sounds a bit fluffy, like, oh, here we go. But it can probably the equipment I've had that has been rejected the most surprisingly has been to do with some sort of either psychological issue as far as somebody's identity and the way it looks, or some kind of a cognitive issue with how easy is it to use. I think it's important for us to remember as clinicians, sometimes the clients we work with are at a very stressful point in their life. They may have had a completely life-changing injury or found out their child has an illness. And when as humans we're stressed or anxious, we don't think that clearly. It's easier for us to forget things. It's more difficult to pay attention. It's more difficult to solve problems. So sometimes we might need to have a certain amount of patience for that and support the clients with materials to refer to later, writing things down, taking pictures if consent's all right. And also we need to consider in the seating prescription, if we maybe want to go with option A, but option A might not be practical for somebody to use properly, and it might actually be dangerous if not used properly, sometimes a different option is actually a better outcome. Next partner cycle I want to bring up is skin protection. Sitting means somebody's at higher risk for skin problems than if somebody is not sitting for long periods of time. We'll go a bit into some of the risk factors, but that needs to be in the back of your mind. Even if somebody's only using a wheelchair for a couple of hours a day, that needs to just be a question that you're asking and that you're doing some of the detective work around. And the last step on our path here, but not at all the least, is function. And I've broken that down into what can somebody do and what does somebody want to do. Absolutely key. And it's very combined with the mental health and the roles that are valuable to somebody in a day. If somebody can't transfer or can't transfer as easily as they could in their old equipment, that it's not going to work. I had a client once that I was called into. It was one of those clients who was actually quite challenging, because you walk in the room and you think, chair looks really good, which is almost worse because it's not an obvious problem to solve. And it turned out it was quite a new chair she'd gotten. Oh, lovely, fits better, easy to propel. But her former chair, she'd actually bought it. She bought it, not really had a full assessment for it. And what was great about her old chair was, though, because it was too big and there were certain almost cosmetic features of the frame, it was stable enough that she would hold on to it during a very partial toilet transfer. And her whizzy new chair, she could transfer in and out of the chair from the mat table from a plinth. But then she didn't have an independent toilet transfer. So that obviously wasn't a successful outcome. The nice thing is, when one part of the cycle is going well, that tends to boost up the other things. When somebody has less pain, they feel happier about life, they tend to follow skin protection guidelines, they have better function. But when something goes wrong, it can drag the other things down. So I'm about to leave goals and benefits, but I want you to keep this in mind with every single assessment you do. And no matter what else I say the rest of today, this is the most important part of every single assessment. Right, so I want to take a moment and talk about skin integrity, because it is so essential for what we do. And I'm going to start with a question to you. We've got another poll coming up. Angie's on it at the control center there. And I want to ask you, how long should we sit?
All right, let's see here. Let's launch another poll. I apologize. We did get a couple people saying they weren't able to click in. I'm sorry. You may have to be on a computer. Not real sure about that. We're to find out from GoToWebinar. Did not have those issues come up last week, but I'm wondering if some folks could be calling in from or watching on a tablet or a phone or something. We'll find that out before our next one. So I'm sorry for you guys who couldn't answer. You will also notice I did just add something into the chat box. We have a couple people saying they're having some auditory problems and some visual problems. So once again, we are almost 1,000 people that are on this. So thanks so much, guys, for bearing with us. And there's these technical things. All right, let's see. Oh, I think a few people, you got a few people on your trick question there, Faith. But in general, we have 14% say 2 hours. We've got 9% that say 4 hours. Nobody's, 4% said 12 hours, and 73%, we've got some experts on the phone, 72% actually said depends. Let me close this poll and give it back to you, friend. You are back on.
Okay, thanks, Angie. And thank you, everybody, for participating. What I will say, don't feel bad if you didn't put it depends. Those other answers can be right too, depending on the person and their individual risk factors. So they're not necessarily wrong, but the best answer is it depends, because some people do actually sit in a wheelchair quite all right for 12 hours a day, but they're on top of their pressure relief techniques, and they may have less risk factors than another person. And when they're out of their chair, they may be doing other things. They may actually be quite active in ways that make them able to do that. In fact, it was so hard to get numbers. I looked at the guidelines from the European Pressure Ulcer Advisory Panel that were also informed by, in North America, it's called the National Pressure Injury Advisory Panel, and the Asian group, the Pan-Pacific Pressure Injury Alliance, I think. None of these names roll off the tongue. Those are available online. The short guide is available for free, and that will be in the notes that you'll get after the webinar if you're interested in that. But I did find some numbers from our national advisory body here in the UK, NICE. They govern the kind of treatment that the NHS is able to provide. And if we look at this quote that I pulled out, it says, encourage adults. So I thought that was very interesting. It's not require adults, demand adults, it's encourage. So already we've got a little bit of wiggle room here. We've been assessed as being at a high risk of developing pressure ulcer. So it doesn't say at an X Waterloo, it doesn't say at a certain Braden scale. Those are very useful measures, and I believe in standardized measures, but I thought it was really interesting that the official guidance is do your clinical assessment, do they have a high risk? And Then the guidance comes in, change their position frequently, and okay, finally, we'll give you a number at least every 4 hours. So they on the very outside. Another official bit of guidance I found in a study from Sharon Sonnenblum and company. I would encourage you to check out anything that they write. They're out of an institute at Georgia Tech University in the United States. Really great research coming out. She posts quite a bit on LinkedIn. But their guidance was to look at doing a pressure relieving technique to really relieve the pressure for about a minute every hour. And because it takes 2 minutes to return to the resting state, in real terms, that means about 3 minutes. So that's the official guidance, but it's very much down to your clinical assessment. So what is it that makes somebody at risk? There's a lot of factors that make a difference. And one study actually I looked at listed over 100. So here's an example of some of them. I'm obviously not going to put 100 up today, but I want to just point out some that might be a little bit of a surprise. Smoking, less and less people smoke, and I'm not saying this is a judgment call at all, but smoking is very much a high risk. It does in fact affect somebody's risk of healing from pressure sores and getting pressure sores in the first place. Here in the UK, if you're ever going in for an operation, the first thing your doctor will say is, do you smoke? If so, can you please stop for 6 weeks before? Age does affect things. Unfortunately, it affects our ability to heal for a lot of different things. And you'll notice I've put in there again, well-being. It's one of those things that sounds fluffy, but when somebody they're struggling with depression, they tend not to care for themselves as well as they could in a lot of different ways. There's some issues here. I'm sure you've probably thought about things like nutrition, hydration, past pressure sores, or pressure ulcers or pressure injury, depending on your local parlance. So just keep in mind all of these things can feed into why somebody has risk. But ultimately, there are only really 4 to worry about. The other thing I want you to keep in mind is that no matter how good your wheelchair seating is, it is also only one part of the puzzle. There's some excellent work being done now about 24-hour postural management. You'll see as we go through, but it's just worth emphasizing 24-hour postural management can improve skin integrity no matter the risk factor. The wheelchair is only one place that somebody is during the day, and because it's the easy place to refer to, you might be the person that then needs to make the referral to have bed positioning looked at, or, you know, do you have the right thing in the car, or, you know, is there an activity where something has dropped down behind you, and that's creating a pressure problem. So I said all of these just boil down to 4 risk factors, and those 4 risk factors effectively are these: friction and shear, moisture, heat. Sometimes those 2 are lumped together as microclimate, and then pressure itself. So let's go through each one and talk about each one in a bit more detail. So what happens in a pressure sore? What causes the pressure sore? It starts with excessive pressure, and it's not just the amount of pressure, it's over the area, the size of the area. If you think about a deep sea diver, they've got the actual weight of the ocean on them, massive amounts of pressure, but because it's perfectly distributed, pressure sores are not a big concern. However, if we take the weight of, say, my partner's cat, who's, you know, a little bit plump, but not the weight of the ocean. If the cat lays on me and has his body over my tummy, fine, oh, cuddly, oh, fluffy cat. But in the morning, if he's ready for feeding time and he sits up with just his paw in my stomach, you know, it wakes me up in a very painful way, and I wonder if I have liver perforation. So it's very much the area. That little paw is really noticeable versus the area of the entire area out. So what happens after excessive pressure? Then there's capillary collapse. Capillary collapse means nothing more than squashed blood vessels. And if you've got squashed blood vessels, it's the next step, local ischemia, which only means that blood's not getting back and forth. And when blood's not getting back and forth, tissues don't get oxygen. All of our body needs oxygen to survive. We all know that. We need oxygen, and so do our tissues. Next step, edema, and which is just another word for swelling. And there's nothing between edema and the very next step, which some of you who maybe have suffered or enjoyed Latin, as I did in secondary school, might know, be familiar with the term necrosis, or that root. So what I'd like us to do, I don't have a poll for this, but because there's nearly 1,000 people here, on 3, if you could just get into the chat box, everybody get into the chat box. I want you to type, if you're familiar with the word necrosis, on the count of 3, one word, what do you think it means? Ready, steady, 1, 2, 3, go. Are you getting like 1,000 answers?
Oh, I saw those people jump in before you even said.
Sorry, I did ready, steady, and I
3.
think people kind of heard that.
Or I did see a friend of ours, Sharon, on there. So I'm gonna say that Sharon, maybe you were a little faster than we got it in the North America over here. But wowzers, yeah. I've got everything from death, which is your favorite one to say, death. Cell tissue death. So yeah, we dying, death of cells. All right. Yeah. I think they got your trick question there.
That's it. That's it. All it means is death. Death is serious. Sometimes I think we have to be very careful, because obviously if we work in this area, we want to support people with disabilities, and if somebody's got a stage 1 pressure sore, which means it's darkened or red, and when it's pushed it doesn't lighten in color, that's a risk. It's time for maybe a tissue viability nurse to be involved, or referral to be made, or to start looking at it seriously before it gets worse, because if tissue dies, you don't always get it back, and certainly if it goes to the bone, it will be a pressure risk forever. There's a lot to get through today, so I'm not going to go to pressure anymore, but just for you to understand what's behind that. So how do we manage pressure? There's, believe it or not, just one formula, and the formula is force over area, or in sort of everyday terms, the weight going through the seat versus the surface that it's distributed over. So the only 2 ways to make it better are to reduce the pressure and to reduce the pressure, you have to reduce the weight or increase the surface area. There's not as much we can do about the weight. There's a few things. Tilt, 24-hour postural management. Look how good it is. Get off your bum. Also, sometimes standing in some chairs, or with the standing frame, is about 24-hour posture management sometimes. But the big thing we tend to work on in seating is that second one, increase the amount of contact with a person. A few different ways to do that. Contouring to match body shape, because none of us are rectangular. So a rectangular cushion won't immerse, and it won't, even the same material won't have the pressure management of one that's contoured to match our shaping a bit better. Consider more immersive materials, and matching the risk level to the person. Sometimes we might be a little hesitant, but go ahead and get the right risk level cushion in there. By the way, there's a lot of information today. All of this is in the notes, so if you don't have time to write it, don't worry, you'll be getting that. Now I'm going to go through the next risk factor, which is friction and shear. I just want to separate what those are briefly. They're often talked about together because of the fact that if you have one, you pretty much have the other. Friction is like a carpet burn. It's on the outside of your skin. Shear is, here's a pelvis. Sadly, my pelvis has had a sad injury. He's lost his femur. But obviously, we have a pelvis, and we have a lot of soft tissue, and then we have the outside world. When we slide, some of the soft tissue sticks, and there's a ripping and pulling between the bone and the surface. That's actually what shear is. It's a little difficult to measure, because you just about have to put a sensor next to the bone, and obviously that's not a practical thing to do. So what controls one tends to control another. And the way to control friction and shear is either make the person more stable and sitting, or make the materials more friendly to allowing a little movement if it's going to happen. People at particular risk, obviously, are people who do sliding transfers, or have tone, or other issues, repetitive movements, where they're sliding and slipping around. As far as stabilizing, it's all down to the right sort of seating overall. But if we're looking at the foundation of sitting posture, which is of course the pelvis, the ways to support it are behind, in front, underneath. Underneath is where considering a pelvic well or more immersive material at the back comes in. At the back, the role of a backrest, sometimes a firm backrest, can make a really significant difference to how the top of the pelvis is supported. And at the front, that's where we look at maybe pelvic belts at the right angle of pull to support the pelvis. The other thing we can look at are the materials. You see here, there's a picture of a cushion with a fluid type material. That's very friendly for shear because the actual material has some movement in it, using things like a stretch cover with a fluid if somebody immerses in it. Air cells can be quite friendly for shear. Considering those kind of issues, as well as maybe in the chair, do you need some anti-shear and powered recline so that when the back goes back, it's not shearing on the person. Last but not least, microclimate, so heat and moisture. And these I've lumped together because often they do go together. You can have issues with moisture and excess sweating and things like incontinence without heat buildup, but usually when there's heat buildup, people tend to sweat. And it's when we're not able to let air to our bodies that heat builds up. There's some articles now actually on the Education and Motion website you can check out that really go into this a bit more depth if you want to read those. But you can think of it now actually as a good time to think about, because in spring right now it's warm some days, and you might feel quite cool with say you're sitting in your car and you've got air flowing over you, but the seat behind you it's foam, and so it's insulating, and you can actually feel, oh, I'm quite hot, sweaty on my back, and that's a factor of the air not getting to the back of you and you having a microclimate heat and moisture build up behind you. So it's quite straightforward, really. How do you control heat and moisture? Reduce the moisture and increase the airflow. So this is where you might consider a cushion that has holes through it. I've got a picture of the J-Light, but there are other cushions, Stimulite, things like that, where there's airflow through the cushion. Look at 3D spacer covers, no matter what the actual cushion material is. Sometimes terry toweling is an option for some people. A thing to probably avoid is synthetic sheepskin. Natural sheepskin may have some pressure reducing abilities, but it's important to remember synthetic sheepskin is actually a form of plastic, so it can be insulating and hold moisture. There are also some exciting cushioning technologies coming out, like fluid packs that actually draw heat away from the skin. So this is an area I think of cushion technology it's quite an exciting one for new developments. Right, so that was a lot of information. I hope everybody's doing all right out there. Stay with me. Now we're going to get into posture a bit. If you haven't watched Amy's webinar and you're interested in posture, a recording's going to be coming out for that. That was the first webinar. This is, of course, the second in the series. That's a really good one to watch as well, and this builds on that. I'm just going to focus here on the pelvis, which is obviously the foundation of posture and sitting, and the associated spinal postures, and what they mean in a practical sort of way. So you might have seen this picture before, something like it, the reference posture. You might have heard it called 90-90-90, and that's because the hips, the knees, feet are at 90 degrees. But I'm going to actually sorry, Angie, I didn't warn her I was going to bomb her like this. Let's try another mass one-word response. How many of you, take a look, an honest look, how many of you are sitting like that right now? Go. Sorry, Angie.
Oh, you're good. You're good. I'm paying attention.
So go ahead and write. Who's sitting like this? Yes or no? Is that how?
Everyone says nope, nope, not me. Oh, I've got a gentleman named Jose who says he is sitting like that. I've got one person. Jose says he's sitting like that. So.
Okay. Well, Jose might be. You know.
Can't see you, Jose. No judgment.
Good on you, Jose.
And we got Michelle. I've got a never. That's awesome. I love the never. I don't. Right. My personal physio or physical therapist here in the U.S. can tell you I do not. I'm a low-tone baby all grown up. All right, I'll be quiet now. Back to you, Faith.
Oh, bless you, Angie. But that's true. Some of you are probably crossing your arms. There's probably a little scoliosis happening. You're probably slumping down a little bit. You might even be supporting your head. But the point is you can get to this posture and then move back out of it. It's when people can't get to this posture and then move out that problems arise. If somebody's always leaning to the left, then tissues tighten on the left and lengthen on the right. Also, in this posture, if you have to go for one, there's a reason to go for symmetry, because if we look here, the feet are supported, so that takes weight off the femurs. We're loading there, so the femurs loading takes weight off the pelvis. There's a nice pelvic well in this cushion, so it's matching the fact that the ITs are about 5 centimeters lower than the femurs. Contouring in the back to match the natural lumbar lordosis, and thoracic kyphosis. Sometimes lower thoracic support is a very powerful thing to do because it helps offload the lumbar spine, and it also can affect pressures in sitting positively. So let's go through the different pelvic postures. A bit of a whistle stop, but it's all going to be there. I've got so I've got a model I might bring out here as well, but let's start with the slides. The nice thing is, no matter how complex a posture might be, a pelvis can only really go in 3 directions. It can either tilt forward and back, wobble right and left into obliquity, or rotate. And it's your job to figure which combination of these are happening, because there are different things to consider with each one. We'll start with posterior pelvic tilt. All of these, by the way, are named for a couple of bony landmarks. ASIS at the front, PSIS at the back. ASIS is a little bit easier to find on most people. PSIS sometimes will appear as a dimple, or it can actually be quite hard to find. If you ever watch elite men's cycling, you might see in their little lycra outfits, you can sometimes, they're so slim, you can see the PSIS. But this is basically slumped back. Slumped back into seating. And what that means is that, well, let's try it actually. Everybody sitting there, everybody just slump down into posterior pelvic tilt. And what you'll notice, oh, I feel like I'm resting now, is that you're not working very hard, aren't you? This posture will probably look familiar to how you are at the end of the day. Oh, long day, man, Faith, that webinar, just man, skeletons, still thinking about it. You're in front of Netflix, you know, because you're not working very hard, and your body is actually fixing itself together. And for our clients that have neuromuscular weakness or fatigue, it is a way to sit. And if the strong downward pull of gravity is pulling you down, it's quite a natural one to fall into for fatigue. And that is a thing that people sort of, in a way, get out of the posture. If we think about where the pressure is, it's going to be on the back here. So just holding my model so you can see it of the pelvis. You sometimes referred to as sacral sitting because you're sitting on the sacrum if it's very severe. What's happening at the lower spine? Well, if you go into your slumped position, it's always nice to try to imitate the position if you want to see what's happening elsewhere in the body. Flattens right out, doesn't it? It's not very comfortable. And the big spinal posture, posterior pelvic tilt, is kyphosis. When somebody has kyphosis, posterior pelvic tilt often will go along with it. At the same time, if somebody has a structural kyphosis and then they're sitting in a wheelchair, then it is likely that may actually drive the posterior pelvic tilt if it's fixed. What about the head? Well, somebody's looking down, they're not really interacting with their environment that much. So if somebody has that position, you may be thinking, just asking the question that you'll answer in your assessment, you know, do we have some posterior pelvic tilt going on there? You may see it as chin poke, because obviously if your head is slumped down, all you can do is hyperextend at the upper cervical spine. So those are the signs to look for. Obviously, the way to really know is put your hands on the pelvis at the ASIS, and then that's how you can feel. And that is also something that was mentioned in last week's webinar. So I want to talk about some internal factors that might cause it. One of the big ones is a tight hamstrings. We have a picture of the hamstrings there. I also have a little model here. Hamstrings cross both the hip and the knee, and when they're tight, this model can't go any higher than that. That's it. So if somebody, and his feet can't come out anymore, if somebody's in a wheelchair and the foot plates are here, the only way he can get there is to slide forward. So having tight hamstrings that aren't accommodated in a chair can be a big one. Also having, we mentioned before, weakness, but also if somebody has limited hip flexion is a big one. Sometimes what people really need is the back to be reclined so they fit. Otherwise, if this is all the flexion they have and they have to sit in something that's spaced like this, you put them there and all they can do is slide forward. They really need the back to open up sometimes. And the way you'll know is really by doing a plinth assessment. But these are the questions you can start going down to match what you're seeing to what you're going to need to do. External, we mentioned about the foot plates being too forward, but also if they're too high and now they're asking the person to flex in their hips more they can, or if they're too low and now the person doesn't have that nice supported posture and they've gone sliding forward, that can be an issue. Or obviously if they had kyphosis to start. So the sister of posterior pelvic tilt is actually anterior tilt. This is another posture that is associated with a lot of weakness. Somebody is fixing in this posture and you can feel quite stable. I'd encourage people to try it. I'm always trying it when I'm talking about it. You feel quite stable actually without having to work that much. The other sort of factor that's maybe why somebody might do this is when you are in this position, you have quite an open thoracic cage. Before, here in posterior pelvic tilt, it really squeezes the thoracic cage. But if somebody has breathing difficulties, weakness centrally, this helps with breathing. So if somebody's already weak and going into this position, that can encourage it. If we look at the head position here, you see what you'll tend to see is either hyperextension or then they might have this retracted tucked position. And that's, to me, I think that's a real sign to then do the assessment and check out, is there an anterior tilt going on? Because that can just be a little bit of a canary in the coal mine if you see that sort of posture, because otherwise somebody might look like they're actually sitting up quite straight and then you find actually that they're dropping into anterior pelvic tilt. So where's the pressure? It's on the front of the pelvis. And what's at the front but the genital area? Not a very nice area to get pressure problems. So if somebody's in a fixed anterior tilt, obviously they need high pressure relief here. If you can prevent it, if they're starting to go there, clients, for example, with muscular dystrophy who are going off their feet, it might be that when they're in anterior tilt, they're going to fix like this. They're going to have lower tone and weakness centrally. And if they're getting a power chair and they have tilt, it'd be worth also considering recline so they can have a counter posture some of the time, because they're going to be coming into anterior tilt because they just don't have the strength when they're sat up. Big spinal association with this one. It was kyphosis with posterior pelvic tilt. It's lordosis with anterior pelvic tilt. And of course, we talked about the head position. So let's talk about some of the reasons other than weakness. It can also be associated if somebody is in lying position where they're prone all the time. There's nothing wrong with sometimes having prone, but if they don't have positioning and counter postures to deal with that. If the foot plates are too low, that might be pulled forward. If the seat, before with posterior pelvic tilt, that can happen. I'm sorry I didn't mention it. If the seat is too long, people might drag into posterior. And here, if the seat is too short, sometimes people feel unsupported and they might come into anterior pelvic tilt. Two of the big ones probably, though, are backrest is too contoured and it's pushing them forward. Or seat rake is too much. A little seat rake gives somebody stability, but if there's too much seat rake or fixed tilt or dump, whatever your local parlance is, that can encourage a bit of anterior tilt. So these are things to think about. I know there's a lot of factors, they're all in the notes, but these are the questions you would want to start asking. And the next one is obliquity. And in obliquity, one side of the pelvis is higher than the other. One thing people get out of this that I think is maybe the one that's a little bit easier to overlook is pain relief, particularly with our non-verbal clients. If you lift one side of the pelvis up, then we're not bearing weight there. Somebody might have old hip issues or hip issues that aren't necessarily known. That's a big one with obliquity. I will make a plea to you with obliquity. Please, when you talk about it, say higher or lower and which side, not just right obliquity or left obliquity, but right side higher or left side higher. And of course, the classic spinal posture associated with this is scoliosis. When we talk about factors other than pain, really anything unequal. So there's unequal bulk one side, unequal tone, unequal strength, people can be pulled into obliquity. Often people with multiple sclerosis will develop an obliquity over time and they need seating to do that, to support that. If somebody has seats that are too narrow, particularly with kids, and parents are just amazing, you know, they do all this work with kids and they're trying to do the right thing and put the kid, you know, in the seating like they should be, but the child is grown, they might actually go into obliquity trying to wedge into too narrow of a seat. A too big seat can cause the same problem because people tend to rotate and fill up the space. So when you see an obliquity, you need to think about what is going on, why is this happening, what's behind it. And with obliquity, there's two basic types, and often there'll be a combination, but it'll either be flexible or fixed. The classic support for obliquity, pelvic obliquity and a scoliosis is to have 3 points of support around the scoliosis. And you see here, if you just sort of the spine, the vertebral column is a series of rings. If it was a tower and your tower was collapsing, it's easy to think when there's the downward pull of gravity, where would we support the tower so that gravity is not pulling on it? And that's exactly where the laterals go, right underneath the apex on the convex side, high on the concave side, and then blocking the pelvis. If there's flexibility, which you will only know from having somebody sit on a plinth or mat table, whatever you call it locally, it is worth lifting up under the low side if they can correct and are comfortable doing it, because that can really help align the spine. However, if it's fixed, all you can do is accommodate it by scooping out under the low side of the pelvis and using the 3 points of support to reduce the risk of collapsing into more scoliosis. One thing that is actually a limitation on this picture, you'll notice my poor old guy here, he's getting jabbed in the right side by the seat because it's not wide enough. And what people really do in real life is they will go into more obliquity. I like these pictures otherwise, so I've used them, but you're going to have to widen the seat to allow the pelvis to drop within what it can. Otherwise, somebody might be forced into more obliquity. So you need to think about, do I need to widen the seat to allow enough space for the scoliosis that's actually going over where the pelvis is? Last but not least, rotation. And this is similar to obliquity. Please, when you're notating rotation, say which side forward as well as right or left, not just left rotation or right rotation. Once upon a time, you could do that. So, you know, much respect to experienced therapists and REs and clinical scientists out there that remember those days, and it was about which way you face, but not everybody remembers that. So just say right forward, right back, left forward, left back, however you want to do it, but please say the side plus right or right or left back. The spinal association is pretty easy on this one. If the pelvis is rotated, the spine is rotated. So it's going to be spinal rotation. The main way you'll notice this one is you'll especially notice that there's often either true hip wind sweeping in the chair, which is adduction one side, abduction the other side on hips, internal rotation one side, external rotation the other side, or if I can get my model straight, sometimes you'll have the appearance of wind sweeping because the femurs are in line with the pelvis, but the whole pelvis is rotated over. But that's a sign to start considering, you know, are we having some rotation here? And obviously rotation is the spinal posture. Factors for this are a little bit like obliquity, and often obliquity and rotation will come together. It's about unequal things, but rather than unequal one side of the body, particularly that affects underneath the pelvis, it's about behind, and often it will be the same thing. Unequal tone will affect, in fact, some tonal patterns, obviously people pulled into rotation. But things like if somebody is deeper one side than the other, particularly if somebody has a leg length discrepancy, that can pull them into rotation, or hip subluxation that then created a leg length discrepancy that's not accommodated. Those kind of things can make somebody pull into rotation. And also things like one side hip abduction or adduction not being accommodated. Often when you allow the hips to go to where the range of motion really is, then you can straighten the pelvis out, and that helps you, the rest of the body have a better posture. So I think I've got the next one. Okay, our slides are hanging out. There we go. Slides back in the room. So that was an absolute barrage of information, but the things just to remember are there's only 3 ways the pelvis moves: tilts forward and back. Posterior pelvic tilt is associated with kyphosis, anterior with lordosis. Obliquity is lateral flexion, so scoliosis, and rotation is associated with rotation. And that's really the questions to ask about that and how you deal with those. So just want to take a moment to talk about actual cushion materials, because it's easy for sometimes manufacturers to say, this is a great cushion, but we need to think about great for who, great for what, great how. You notice my surroundings have just changed, as well as my uniform, and that's because on the day of recording, we didn't have enough audio and video quality for this next section to use that in the ultimate webinar recording. So this is a fresh take. Benefit of that is that since that time, 2 weeks ago when we did the live webinar, some new resources have gone up on the Education in Motion section of the Sunrise Medical website, particularly in North America, but they're coming to Europe. And these resources are all about the next section, which is all about cushion materials. There's some printable PDFs there, a couple of blogs. So I really encourage you to check out that resource that's gone up just since the original live webinar went out. First material I want to talk about is foam, by far the most popular material in wheelchair cushions. For many users, their first wheelchair cushion will have at least some element of foam. The good things about foam are it's inexpensive for the user and to manufacture compared to other materials. It often can be modified in the field for customizations. It's lightweight generally compared to other types of materials. Some foams have special materials. Viscoelastic foam tends to absorb vibration and can feel quite subjectively comfortable to a user. Some downsides of foam, though, are foam is made up of so many little springs effectively, and over time, those springs don't rebound as well as they used to. So over time, it will need replacement like any cushion, but it will compress over time. The other thing about the fact that foam is pushing back against the user is it's exerting a bit of a counter force against the user. Basically, very tiny little springs always pushing back against the user. And whilst a person can have fairly good pressure relief, very good pressure relief from foam, it does top out compared to some other materials because it will always have a little bit of a reactionary force. The other big downside of foam is probably that it's an insulating material, just like you might have in your house. Spray foam that insulates the wall. Foam under a person is insulating, and why that matters is when heat and moisture levels build up on the seated surface, as we talked about, microclimate is one of the risk factors for skin breakdown. Other thing about foam, it comes in two basic types: open cell, closed cell. Open cell is the most popular in most cushions because it's the most forgiving, has the most types of firmness and density, but because it's like a sponge, it will need a coating or a cover of some sort, usually to protect it, to protect the material from moisture. Closed cell foams, a person could hose down, but they tend to be quite firm. Sometimes they're used as bases and cushions, or they may be the cushion itself. Often in those cases, the seating relies heavily on contouring to match the person's anatomy so that it provides the right support and it's comfortable. Next material I want to talk about is gel polymers. Some examples of this are like the Actin gel polymer or Gelovation Synagel. What's great about this kind of material is because it's effectively like a very firm gelatin, it's very good for shear forces. So rather than the person's skin shearing, the material takes some of the shear. It also can feel subjectively cool initially, but it tends to warm up to body temperature. Last big advantage of gel polymers are that they can be put in tiny places other materials might not go. Some of them are extremely thin, sometimes only a centimetre or two thick, and so they can go on things like foot plates and armrests. And if somebody has a backrest that maybe is getting replaced and you need something to go in really quickly, a little bit of gel polymer can do it. You can cut it and really modify it in the field. Downsides of gel polymers are, though, that they're extremely heavy. They're probably one of the heaviest materials in a cushion. Luckily, they can be a bit thinner, so that helps offset the weight, but they can be quite heavy. They also don't immerse a person very much. Sometimes you see, like on this slide here, gel polymers can be castellated to help reduce surface tension so that somebody immerses a bit better into them. But sometimes users can almost sit a bit on top of a gel polymer. Or if somebody's lighter weight, they really don't immerse that well in gel polymers. So they have their place, but that's a big downside to consider with them. Air, which technically is a type of fluid for those of you who are up on your science, but air, particularly air flotation cushions like the examples you see here, is excellent for immersion and pressure relief. It displaces under a person. It doesn't push back like foam does. Downsides are air flotation cushions have to be pumped up, and there's a real maintenance requirement there. Also, somebody needs to know right away if they deflate, because while they can be excellent at pressure care, they can be the worst at pressure care if they're used improperly and they've deflated or they've punctured and it hasn't been noticed. So it's important when somebody's getting an air cushion that they have either themselves or in their care environment the ability to use it properly and continue to monitor it. Another advantage of air is it's extremely lightweight, and sometimes, depending on the type, if you have a dual chamber or a 4-chamber or more air cushion, you can actually modify it by inflating parts of the cushion more than others in the field. Keeping in mind that may also increase the complexity for the user down the line if they have a complex inflation to monitor and maintain later on. Last one I want to talk about today is fluid. These types of materials that you see here, what's great about them is they disperse under a person. So rather than pushing back like foam, they actually flow out of the way. And one of the great things about that is when we talked about pressure, the ways to reduce pressure are either reduce the force going down through the seat or increase the surface area. And fluid really matches all the anatomical lumps and bumps by letting the person sink into the material. Downsides of fluid are that it's a little bit heavy. You've noticed on the cushions here, fluid just covers part of the cushion, the most important part under the pelvis to really sink and immerse the pelvis. But if the whole cushion had a lot of fluid, that starts making the cushion relatively heavy. Other thing about fluid, it's not as much maintenance as a dynamic air flotation type cushion, but it does have some maintenance. It does normally need to be squished back into place end of the day, particularly if there's a lot of fluid and the person really sinks into the pelvic well where the fluid is. There are some cushions that have technology to reduce the amount of maintenance, but that's something your provider can help you talk through if the balance between how much somebody's going to have to maintain it versus how much fluid you really want to have under them to immerse the individual. This is a diagram of what I was talking about with the reaction force of foam versus hydrostatic force, which is the displacement of fluid like an air or a fluid sac type cushion, and why that's so good for pressure care. And because cushions that have a fluid insert do need to disperse, it's really important that they have a pelvic loading area that's shaped to a person's pelvis so that they have stability in the cushion. So that's going to be key whenever you use that sort of cushion. So to summarize, this is an example of one of the resources that's available at the Education in Motion site in your country. This is the UK European version of pelvic and spinal postures. I'll also send a link through in the second follow-up email for participants, and if anybody goes to the website, you can download this PDF. It's very useful, as well as the brand new PDFs that have come out about cushion materials. Really want to thank everybody today who participated in the live webinar, or those who are watching the recording as your first exposure to this material. I really appreciate you taking time today. I hope it's been useful. Sunrise Medical want to support you in the work you do with your clients, so please don't hesitate to get in touch with your local Sunrise, or if you're in the UK or Ireland, get in touch with myself because I'm the clinical specialist for UK Ireland if you have any training needs or want to discuss your client needs in any way that we might be able to help you with.
And that's a wrap for this webinar. But don't worry, this was just the tip of the iceberg when it comes to the resources available to you on the wheelchair provision process and seating and mobility equipment. Be sure to visit the Education in Motion portal found on the Sunrise Medical website for even more valuable information, including additional webinars, printable resources, links to various industry websites and white papers, user case stories, and much more. Once again, thank you for watching, and if you have any questions or comments, do not hesitate to contact us at eim@sunmed.com.